Hi everyone, my name is Sandra Rogue and I'd like to welcome you today to today's Connect and Learn webinar, Streaming the Referral Experience. I'd like to start though by acknowledging the traditional owners of the land on which we're meeting today, and for me that's in Wattle Glen in Victoria, the land of the Wurundjeri people. And as we are all in diverse locations, I'd also like to pay my respects to all Aboriginal elders past, present and emerging, and to extend this respect to all First Nations people. Just before we get started, there is some housekeeping, just a couple of things to go through. If you would like to ask a question, please do so at in the question section of the webinar. You will be able to download today's presentation. The PDF version is available to you. There's also a tip sheet that's been put together by the presenters and the network of workers who've been informing this webinar. You do also have an opportunity to provide us with some feedback about this webinar and any other webinars that you would like to see in future. So please don't hesitate to let us know about those. This webinar is being recorded and it will be available at the Turning Point website in about a week or so. Today's presenters, I'm very pleased that they've been able to be available to do this in their busy schedules. We have Rebecca Smythe and Goldie Nemirovsky. And Rebecca is the unit manager at DePaul House, the residential withdrawal unit, and she's been there since 2018. And this is part of the St Vincent's Department of Addiction Medicine. And Goldie is the Senior Intake and Assessment Advisor at Windana for the Adult Residential Withdrawal Unit and currently leads the admission team. And both presenters have kindly made their email addresses and phone numbers available for you if you'd like to ask questions at a later date. It's just the presenters have asked for these to be the objectives, and a reminder that if you haven't got it beside you already, to have the alcohol and drug comprehensive assessment so that you can walk through this at the same time as they're presenting. So there are some objectives here, they're about providing information to you, the Victorian AOD clinician, on how to enhance the quality of the assessments prior to clients seeking admission, and identifying key information required for every assessment for both the medically supervised and the community residential withdrawal programs, which are different, and provide an opportunity again for questions from you, the field, and to provide relevant resources and links to the essential documents. I'd just like to let you know those people who've already submitted questions, they have been forwarded on to the presenters as well. We like to get things going sometimes with a poll, so here's your opportunity. So if you'd like, please launch the poll. And this poll is asking you about how confident you are at completing the alcohol and drug comprehensive assessment for residential withdrawal. So are you very confident, somewhat confident, or need help? Okay, so if we could close the poll and we have a look at the results. I can't actually see them, so I'm not sure what we do with that, but we might just keep going on. Can anyone else see the results from the poll? Oh, we'll keep going. But hopefully by the end of the presentation, some of those responses might have changed, or you've been reaffirmed that you're on the right track. What I will do now is hand over to Rebecca. Now, Rebecca's on audio only, so we just had a tenuous connection, so we're going to maintain her on audio. So I'd like to welcome Rebecca, and you can start your presentation here.
Perfect. Thank you, Sandra. Good afternoon, everyone, and I do apologize again for the connectivity issues, and I just hope that everybody can hear me. I wish to thank Sandra as well for the acknowledgement of country and for explaining today's objectives. I will be asking Sandra to flick through slides, unfortunately, but I'm grateful for Sandra's help, so just bear with us on that one. I will also be getting through the documents pretty quickly and summarising in my delivery of the session, so please don't be put off as I appear to be gliding through at pace. and trust that all the slides will be available via the Turning Point website for those interested to access or review at any point. Okay, over to the next slide. Okay, so anyone referring a client for medical withdrawal should be very familiar with the 7 modules which make up the AOD Comprehensive Assessment Tool. Of these 7 categories, at DePaul House, we require particular care to be given when filling out the medical history and current prescribed medication categories. This information around clinical needs is often the point of difference between a general community residential referral and a medical one. Okay, next slide. Okay, so what constitutes a medical withdrawal? One common assumption is that we are situated inside or attached to St. Vincent's Hospital, which we are not. We are, however, located on the hospital campus, which means that we take clients both in a crisis capacity from the emergency department and clients with a more complex medical history via the usual intake AOD stream, which most of you here today would refer via. This level of responsivity means that we accept clients from all regions and those who are not necessarily fully linked within the AOD system also. Our objective is to provide medically supported withdrawal from symptomatic treatment and monitoring with medication available 24/7 as required. We also offer medical stabilization and commencement of treatments such as long-acting injectable buprenorphine, and this is also a common focus of admission to the DePaul House. Next slide. So another question commonly asked of our intake worker is, what is the difference between DOAM, or the Department of Addiction Medicine, and DePaul House? So to put it simply, DOAM refers to the Department of Addiction Medicine, which is an outpatient clinic at a separate St. Vincent's Hospital location to DePaul. This is where the team of addiction medicine specialists, psychiatrists, and counselors sit. They offer 24/7 support to DePaul House and allow us to facilitate medicalized withdrawals of high acuity. In short, DePaul House is the inpatient component of the Department of Addiction Medicine. Though oversight and clinical review is provided to DePaul by these consultants, our intake streams are largely separate. Okay, next slide. Okay, so Module 1. Another one of the key deciding factors in whether or not a client necessarily warrants a medically contained withdrawal. Due to our need to prioritize those who are physically compromised and require high levels of medical care, we do not accept clients using cannabis as a single substance or those drinking less than 6 standard drinks daily, unless significant comorbidity exists with that person. So you can take a look at some of these reasons in black below. Similarly, and quite dramatically contrasting to Windana, for example, no amount of polysubstance or severity of usage is too high, aside perhaps from clients using extremely high doses of benzodiazepines who may be asked to self-reduce prior to admission. In a nutshell, unless your client has identified medical risks in the presence of lower levels of usage, they will likely be redirected by us elsewhere for non-resi withdrawal. It's important to note here that your identification of quantity is essential. Street language such as speedballs, cones, etc. is not ideal, and we do expect that you try to extract quantities from clients such as milliliters, grams, or points. Next slide. Psychosocial. So some of the more commonly underreported data we receive is within the children, housing, and legal categories. Using acronyms for legal and family intervention orders is best avoided, as there are so many types of orders that clients can be subject to, and we're not familiar with all of these. Similarly, a family or corrections order should not be listed without explanation of the conditions of said order. For example, what is the person's specific access level to their children? What are the contact details of their corrections worker? Stating just names and locations does not suffice. We do accept homeless clients at DePaul, but a documented plan of how this will be resolved needs to be clearly evident to us. Similarly, just writing supported accommodation offers us a less rounded picture than a description of the nature and level of support provided. Next slide. Okay, so the clinical diagnoses are welcome and appropriate for DePaul House referral. Much like substance usage, no medical issue that is not in an acute phase is really a limiting factor, given our 24-hour nursing and medical cover. We do, however, expect a GP summary or specialist letter to support the referral, which you can submit together with the assessment paperwork so as to be on the front foot. For example, ticking the box for cardiac issues is insufficient in the absence of a medical letter or detailed explanation by you as the referrer. Okay, next slide. Okay, so mild to moderate mobility issues as well as visual or hearing impairments are accepted at the poll. We also accept those with mild to moderate learning disabilities, such as clients with autism spectrum disorder or clients with an acquired brain injury. One thing to be mindful of, though, is that if you are reporting to us that a person has an ABI, we need clarity around who formally diagnosed it. For example, is it listed on their GP summary, or have they had a neuropsych assessment historically? Very often, terms such as ABI, chronic liver disease, and asthma are loosely described without any context provided. Okay, and over to mental health. Next slide. So DePaul House is not a dual diagnosis unit in an official capacity. However, due to our staffing profile, including psychiatric nurses and psychiatrists, we do accept those with slightly higher chronic risk than community units such as Windana, for example. Often we see multiple mental health diagnoses listed in the comprehensive assessment, some of which are conflicting in nature and offer us an unclear picture of the client. We do understand that assessors are not necessarily trained in this area. Therefore, if you are unable or unsure to provide further detail, please seek a GP summary or letter from the private psychiatrist if there is one. If a client describes an ADHD diagnosis, past or present, which is very common in our methamphetamine using cohort, it is essential that this statement is supported by the details of the dexamphetamine prescriber and/or a medical summary. And similar to medical issues, if the client has had a mental health review or an inpatient admission within the last 3 months, we expect a discharge summary would support their referral documentation. Next slide. So probably one of the most important areas of the comprehensive assessment for us at the poll is the current prescribed medications. As I mentioned at the beginning, we focus predominantly at this section within a medical setting. I can't say GP summary enough, and it should be as recent as possible. GP summaries are your friend for not only spelling of medications, but for accurately describing to us the full diagnostic profile of the client. I still struggle with spelling and terminology of some medications and diagnoses, so you can imagine how difficult it sometimes is for us to decipher these depictions from workers who are not necessarily from a clinical background. Also, it states in big and bold lettering, no matter how insistent the client is, we unfortunately do not accept clients coming off opioids who wish to do so without OST. This directive stems from our clinical directorate and is viewed as best practice by the Department of Addiction Medicine at St. Vincent. Next slide. Okay, so aside from medical risk, 4 main areas of concern for us regarding risk are IVOs, suicidality, sexual safety, and aggression. It is not enough to tell us that there's an IVO in place and when it commenced. We need to know as much about this order as possible. For example, can the client have phone calls or partial contact with the person? Has there been any breaches? We need clarity around whether the client is a victim or perpetrator of domestic violence, as this is really helpful in our management of them. With regard to personal safety or suicidal ideation, we really need to know if the client is likely to unravel in withdrawal and how that may look so we can problem solve it. Chronic self-harm is not necessarily a barrier, and omitting this info or tendencies to self-harm when stressed does not help us in building the most robust, individualized plan possible for their admission. Next slide. Okay, so we aim to be accepting of clients' forensic history at the poll house, and we will accommodate those who may have a history of assault. However, it is important that the extent of their aggression history is detailed. If a client has a previous charge of GBH, aggravated assault, or attempted murder, we may request more information, suggest a pre-meet, or decline the referral based on safety concerns for the unit. Due to our mixed male and female cohort and lack of gender-sensitive areas, clients with convictions of sexual assault, sexual misconduct, or sexual harassment will not be accepted at the home house. Next slide. Okay, so the final summary section offers you the space to provide us with a real sense of the client and what the client wants to achieve. If this withdrawal is just a circuit breaker and the client is not fully sold on rehab, that's okay. We're not the motivated for treatment. Under the harm minimization model, we are happy to explore this and accept clients, even if it's just to achieve abstinence for a medical procedure, for example. Bed-to-bed follow-up of clients at Resi Rehab is desired, but it is in no way essential or a barrier to treatment. And lastly, stating where you have referred the client to helps us to prepare for the event that the client is accepted elsewhere, and this allows us to have another client on standby to take their place. Saying so does not spook us or make us less likely to accept. Okay, and that's it from me. I'll be ready and available to answer questions once Goldie's finished. Thank you.
Thanks, Beck. So there are a few key differences between a community residential withdrawal unit and a medical residential withdrawal unit, which I will touch on in my slides today. But to start, I just want to share also a few key aspects about Windana Detox. So our length of stay is usually between 7 to 10 days. The staff at Windana work from a culturally sensitive, trauma-informed, holistic approach, considering any medical conditions, mental health issues, and the social circumstances and how this links to the client's drug or alcohol use. Both contemporary medical treatment and complementary therapies are offered. So the complementary therapies come in the form of naturopathy, osteo, acupuncture, art therapy, yoga, and educational support groups. So what are the key differences between a community residential detox and a medical residential detox? So with a community residential detox, nursing and medical support is only available between business hours. Medical support is provided by the GPs in the community. Medications are provided by a local pharmacy. We use a fixed schedule dosing. We are not connected to a hospital or addiction medicine specialist. Whereas with a medical detox withdrawal, they have 24-hour staffing available. Medical staff are provided by the staff of the unit. Medications are available from on-site stock. There's greater flexibility with medication administration due to access of nursing staff. They use a fixed schedule dosing and symptom-triggered dosing regime, and they are connected to a hospital and addiction medicine. So there's just a duplicate in slides, so I'm just going to move on to the next one. So what are the key differences between fixed schedule dosing versus symptom-triggered dosing? With fixed schedule dosing, it's a withdrawal medication is provided 4 times a day in a decreasing dose. No additional medication is available without taking the client for a review at the GP or getting a phone order in. Whereas with symptom-triggered dosing, medications are provided based on assessing the client on a withdrawal scale, and as well as additional medication may be provided based on the symptoms presented. So how much is too much for a community withdrawal unit? So when it comes to the amounts of alcohol, anything above 3 liters or more is case by case, but generally rule of thumb, we would say nothing above that. Anything above 30 mils when it comes to GHB, and greater than 20 milligrams of prescribed or illicit daily use of benzodiazepines. So medical concerns that are not suitable for Windana generally would be any unstable health conditions such as diabetes. Just move on to the next slide, sorry about that. So anything in terms of unstable health conditions such as diabetes or heart conditions. If a client is reporting seizures during withdrawal, it's really important to be curious because often the clients do think they have had a seizure, but in fact it's not. So if you're not sure, doing additional follow-up with their doctor or any previous detox units that they've been to before may be able to add additional information around whether they are genuine seizures. If you're unsure, just give us a call and we're happy to talk it through with you as well. Other health concerns that aren't suitable for Windana would be clients diagnosed with diabetes that requires a sliding scale of insulin to be calculated according to their blood sugar levels, as well as any additional pain management support that requires adjusting during admission. So what we do want to know when it comes to clients' current level drug and alcohol use. So how much are they using and how frequently? What happens when they stop using? So for instance, do they experience seizures, vomiting, perhaps even bleeding as well? So what are the physical signs of their withdrawal? What time do the withdrawal symptoms start? Another question that's really important to ask the client is, how long have they been using at this particular level for? So this is particularly relevant when we are referring to benzodiazepine use. The next information that we want to know about is around psychosocial. So where is the client living? Is that accommodation stable? If it's not stable and they're homeless, have any housing referrals been made? Do they have housing support? How many children do they have? If they do have children, where are the children residing? If they are in a relationship, is there any presence of family violence as well? So having the information around who their supports are in the community is also really helpful because often that can fill in the gaps of any information that's missing too. So I'm not going to go through all the health concerns that are listed on this slide, but in general, we would want to know if the client does have mobility issues. Are there any chronic pain concerns? So what are the causes of the chronic pain? How is it managed? If there are any diagnoses of an ABI, if the client has completed a neuropsych report, then that's really helpful for us to have that as part of the referral too. When it comes to diabetes, is it type 1? Is it type 2? Is their diabetes stable? Are they insulin dependent? So the next slide is around mental health. So I just want to mention that it's really important to complete the MSc because it often gives us a comparison of how the client presents to you and how the client may be presenting to us. So we can identify any concerns and similarities at that time when we speak to them as well. Listing the current diagnosed mental health concerns is really helpful. Are they prescribed medications and are they responding to the medications well? Like, is it supporting the symptoms? Any presentations of auditory or visual hallucinations, delusional thinking, paranoid thoughts are also important to list. The other dot point that I wanted to touch on is behavioral concerns. So, it can be difficult to really explore that during a one-off session, but finding out how the client would go in terms of a therapeutic group, how would they respond to rules? So if they can't respond to rules well, and that might create an issue in the unit as well as non-participation concerns. So if the client's had any recent hospitalizations, having a discharge summary to support the referral from their stay, particularly if it's in the psych unit, can be useful for us as well to have as part of the referral. If they have a history of suicide attempts or self-harming, we do need to know that information. And if you can provide us more context and less, that's always helpful for us too. So you may have completed a safety plan as part of the assessment with the client. So if you can provide that to us with the referral, that would be great. But also any of their professional supports in the community may have created a safety plan with them as well. So then you can actually access that from the professional supports and provide that to us so we can utilize it during their stay in the unit. So the next slide touches on medications. So we really want to know who their doctor is, who's supporting them in the community, their doctor's details. What are they currently prescribed? Are they compliant with their medication? What are the doses? How frequently are they meant to be taking it as well? So similar to Beck, we do request a medical summary to come as part of the assessment, because then we can verify the medications they're on and the dose. And as I mentioned earlier, because we use community-based GPs, our doctors don't necessarily want to be prescribing medications that they haven't prescribed to the client before. So having a GP letter to verify that is always useful. In addition, if a client is on a depot antipsychotic medication, that can be complicated to get our prescribed GP to give the client in the unit. So our preference is actually to have the client have their dose before they come in. When it comes to legal concerns, what we want to know is actually current and past charges. So past charges are just as relevant, particularly if clients have a history of using weapons, if there's a history of violent assaults or sexual assaults. When it comes to the context of the sexual assaults, we just want to know what was the context that it happened in, how long ago that happened, are they on the sex offender register, and are there any conditions as well. So if there's DHS involvement, we want to know what the order is, who they're being supported by in the community. Are there any IVOs in place? Who is the perpetrator, and is there an IVO against the client as well? So if you contact the client's corrections workers or even drug court, often they can provide you a LEAP report that can assist with the referral, because if a client does have a history of violent assaults or weapons, that often gives us a better picture of the history as opposed to basing it on the client's memory as well. So with the discharge summary, we really want to know where referrals have been made and also who will be working with the client on discharge. So I think what I find with clients in particular, if they have no discharge plan, it's often disheartening for them because 10 days just doesn't feel like a long enough time to address all the issues that may come up for them. So when we can't accept the referral, this is generally if the client is withholding information or consent, then we aren't able to assess them for suitability. If there's any behavioral concerns such as violence or aggression that isn't managed, non-participation concerns, there's concerns of violence towards professional supports. We can't accept referrals for cold turkey opiate withdrawals, as well as clients who decline ORT on discharge when they're reporting regular use of opioids. So just the final thing I wanted to say, please feel free to give us a call and discuss your referrals. We're very happy to have a chat about them and let you know if there's any extra information that we need in case you have missed it too. And in addition, if there's any changes to the client's phone number, medication, substance use, perhaps any ED presentations as well, it's really important that you get that information to us as soon as possible, because it can delay the process of us reviewing the referral as well. So thank you all for tuning in today.
I just realised I'd been mute. So thank you very much, Goldie. Thank you very much, Rebecca, for your presentation. We do have an opportunity to launch another poll in a moment, but I'd just like to say this is also an opportunity for people to get in some questions, because we do have a little bit of time for our presenters to answer those, and I'm sure that there's plenty there. We do have some from earlier, so we can also ask those for those people who would like to get a response from people who are working in the field at the coalface, so thank you. So we will launch the second poll, and I'll be able to compare results So thank you very much if you could do that. So just whilst you're completing that, first time around the poll was people were describing themselves as very confident, about 20%, somewhat confident, 60%, and need help, around 14%. And post-webinar information, still needing help, it looks like it's between, I think it's 7.1, somewhat confident, 42, and very confident, 50. So thank you, because that's kind of reaffirming that you're probably all working within the right space and responding to completing assessments effectively. What I'd like to do is to open up the floor to Rebecca and Goldie and ask them to respond to maybe some of the earlier questions that came in. One was just a quick question or response from you guys about advising clients that smoking is not available, and how do you respond to that?
Yeah, look, I guess I'll respond from a medical standpoint. At St. Vincent's Hospital, we are, I guess, unfortunately, some would say, subject to the smoke-free campus policy. It is a bit of a barrier for a lot of clients, especially those that are going to rehabs where they know that smoking will be allowed, because it doesn't really, I guess, sit with them that they have to abstain from smoking in detox, but then will be able to smoke again in rehab. How we manage it is we just make sure there's a lot of prep work between our intake worker and the person referring the client in just preparing them, letting them know there'll be nicotine replacement therapy available to them. And yeah, I think we can often look at things like a slightly shorter admission. It's not unheard of at DePaul House to do even a 6-day admission, or, you know, try and just make it as seamless as possible for them so that they're not under too much distress, as well as having to go through the withdrawal.
Goldie, would you like to respond too?
Sure. So with Windana, we actually haven't gone smoke-free, but we do have allocated smoking times. We have a smoking area as well. So clients can't just go smoke whenever they like, and that's something that the staff will talk with the client on admission about.
Okay. So
the other thing is, sorry, I forgot to mention as well, Sandra, we ask that if clients do bring in cigarettes, they are in a brand new packet, and if they smoke rollies, there has to be a new packet as well.
Okay, thank you. Okay, there's another question here about, will you accept referrals and admissions direct from inpatient and mental health units?
I'm happy to answer that. Oh, do you want to go first, Beck?
No, you go ahead, Goldie.
Okay. So it depends if the client has been there already for a week, and often we find that clients who are in a psych unit may be there for 7 days, and hence that's a withdrawal already. But it depends if they suspend their leave or not, and the client is still using whilst they're there. So I have heard before of clients who still need to come in even if they've been in the psych ward. So if they're not reporting any physical withdrawal symptoms, then we can't necessarily accept the referral. Do we accept referrals from a inpatient unit? If they're able to complete a comprehensive assessment, which is the Turning Point tools, then we can accept the referral from them, but we just really need to, I guess, get a better idea of what would the purpose be. Why are they actually needing to come in if they're already in the psych unit?
Rebecca, would you like to respond?
Yeah. Look, Goldie pretty much answered that, similar to what we would expect, but the only addition would be if that person was wanting to commence on oral substitute therapy or long-acting injectable, we may have to admit them for monitoring for that. But that would be probably one of the only reasons, if they'd already withdrawn in the psych unit, that we'd be taking them in.
Okay, and thank you. There's a question here. Can you advise how detailed the brief case formulation, the final case summary, needs to be? So, Goldie, would you like to start?
It seems that the final case summary, it just reaffirms everything that you've identified in the comprehensive assessment. So if you can, sum it up nicely in that section, it's not really how much we need. It's more so how much it paints the picture of the client's story. So it does touch on their substance use, their mental health, their physical health, and what their plans are after detox as well. So I can't really give you an exact answer, but if you can reflect it well in short sentences, then we're happy to accept that.
And Rebecca, did you have a response?
Yeah, look, most of the comprehensive assessments that I would cite, that section is really just copy and pasted from further modules or further sections that people kind of use that as like a bit of a dump to just put all the information in one last summary. But I would kind of hope that it would be used for really capturing the person's motivation for treatment, or if there's something that you might have missed in some of the other modules or you don't know where it would fit in and it wasn't a tick box or there wasn't an option for it, that you use that space to even just bullet point some other facts about the client that are going to be better able to give us a picture and sense of the person.
Okay, thank you. There's another question here around forensic clients. It says here, previously worked with forensic clients and have been informed that legally police and etc. are not able to advise whether a person is on sex offender register. This information was obtained by a socket officer. Do you want to make a comment about that, either of you?
Yeah, I can. I guess in the jurisdiction that we work in drug and alcohol and mental health, it's rare that we ever get any kind of confirmation or information from police. It's usually from workers. And, we wouldn't ask that we actually cite an order or a tangible document to state that a person is on a register or has committed an offence, but we do rely very, very heavily on what it is that you know. So whether it's a socket officer, whether it's an AXO worker, whoever it may be, if there is a mention or if there's an assumption that can be teased out with the client that there is a history there, we just want to know about it.
Goldie,
I'm also happy, so the reason we ask around conditions as well, because Windana is within a few school zones, so we would be breaching, a few rules around school zones if we brought in someone who wasn't allowed to be within, whether it be 10 meters of a school zone. So that's why we do ask about the conditions, and often the client will know better than perhaps the police. But it is information that we do request if they are on the sex offender register or have any history of sexual assault.
Okay, thank you. There's another question here around, we're funded to undertake alcohol and drug comprehensive assessments every 12 months. Yet I note that DePaul House are requesting a comprehensive assessment that's no older than 3 months. And do you also accept an updated self-complete tool and a summary of changes in circumstances? So for you, Rebecca.
Yeah, so yes, certainly if it's around usage, the self-completion tool, an updated version of that is perfect to capture the obvious changes and patterns of usage that would occur. We don't want old information around a client's usage because in reality it changes all the time. The reason we might request a comprehensive assessment to be redone is that if a client's coming to DePaul House, the likelihood is that there is medical comorbidities or some other extenuating factor that is making that person suitable or going to be better managed at a medicalized withdrawal. So that's probably the reason for that, because the self-complete doesn't really detail or give a adequate enough picture of the client on a kind of medical or mental health front.
And is the same the case for you, Goldie?
Yeah, I definitely say so. So even if the assessment is done a month or two ago, frequently the information will change very quickly. So, that's why we ask for the updates. And we are happy at Windana to receive an update on just the general gist of information around substance use, mental health, medications, physical health, legals, discharge planning, any updates in medications. And we're happy to send you a little prompt around what we want as an update. But as a rule of thumb, if it's outdated, there's no use sending it to us without an update, because then we can't assess a client accurately for suitability.
Okay, thank you. There's a inquiry here as to whether you take interstate referrals.
Yeah, at the Paul House, we most certainly do. It's not common. Some from up around the border, New South Wales border, and some who perhaps have intent to move to Victoria but are in the process of moving from a different state. It all depends on that person's follow-up. If their follow-up plan is secure and if the need is there both substance use-wise and medically, then they will be accepted.
Okay. And for you, Goldie, Sam?
We are happy to accept referrals from interstate as well. And we often have clients who may come to Windana Detox and then go to a rehab in New South Wales as well.
Okay, thank you. There's an inquiry here about, is there a central point or unit that you report to that then advises referrers or services of the current wait times?
Yeah, I mean, look, as a standalone service at the Paul House, our main, I guess, sector involvement and collegial sharing of information around wait times and such, it would occur via Turning Point, actually, mostly facilitated by Sally and with all of the intake workers at the community and medicalised withdrawal units. And we locally share that information between us, but it's so varied among the services that I think it's best if you have a particular query about a particular unit, you just need to contact that unit. There's no central database as such that you can access.
Thanks, Rebecca. And for Goldie, you're much the same?
Similar to Beck. We don't have a central database, but if you contact us directly, then we can tell you what the wait time is. That said, though, I might say the wait time is 8 weeks currently, and then have a cancellation within a week time. So it does change and it fluctuates.
Okay, thank you. And a question around completing the tiers. Do you need the tier 1 to 5 completed in the final case summary? And also, do you accept AXO forensic assessments instead of AOD comprehensive assessments? Oh, double whammy there. Who'd like to start?
Yeah, at the Paul House, I'll be blunt and honest. The tier system, we really don't pay that much mind to, as in the kind of numerical side of things, because what we care about is the prioritization of the person's medical and substance needs. So if they're on that kind of upper echelon of usage and they've got a pre-existing medical comorbidity, they're automatically going to be in a, I guess a more pressing need of a withdrawal from our perspective. And we do accept AXO forensic assessments if the quality is such that we do not need the comprehensive assessment and if it's current. Generally, we find that AXO assessments are not as current as the comprehensive.
Okay, thank you. Goldie?
So likewise to Beck, we don't really pay attention to the tier as such either. It's more useful to have a detailed comprehensive assessment than to be able to identify what the tier score is. We are happy to accept the AXO forensic assessment too. But often I do find that I have to go back and request an update. So if you can provide us the AXO forensic assessment and then perhaps an update alongside it, that would be really helpful.
Okay. I was just thinking from the perspective of a new employee to the role or a new staff member to the role of assessments. So what are some of the key kind of things, just take away for them? What are the absolute key elements do you think might be important for each of your services so that they know that they're going to get a better outcome for their clients? you want to start, Goldie?
Sure, I can start. Having as much detail as you can around their substance use and the withdrawal that they experience is helpful for us. As I said, we only have nursing staff available within business hours. So, if there's risk of their health concerns becoming unstable, then being able to note that down in the assessment is important as well. So being as detailed as you can around physical withdrawal, their physical health history, their mental health is pretty much the information that we do request to be able to assess a client for suitability, as well as, I would say, definitely mental health too.
Okay, thank you. Rebecca?
Yeah, just to add to that, I think just continually be mindful that it's not just you, I guess, building this picture of the client for us. Utilize your resources, and if there's a psychologist or a GP summary or a discharge summary that you can request or you can access from a person's most recent admission, or if they've had a psych review for meds, anything at all, if you can give us that, it almost puts that admission to the top of our pile, because we don't have to then come back to you and request it. It's already done. And I get that it takes time and things are not often immediate, but if it would be one piece of advice I could give to people coming into the role, that would be it.
Okay.
I second that as well. I think it's really, really helpful to access their professional supports to fill in the blanks for you.
Thank you. Great tips. There is a comment here about, can we please get an automatic reply via email for referrals of acknowledgement of receipt? Is that possible?
We actually already do that when we have processed the referral. So once the client's assessment has been uploaded onto our portal, they would get a response just notifying them of that, and then they'll get a second response to let them know whether the client has been provided with an admission date or whether we are recommending something different.
Okay. And for DePaul, Rebecca?
Yeah, we don't have a receipt of acknowledgement, because that would essentially just be like an out-of-office type bounce back, we have received your admission. It kind of goes without saying that we've received it. If it's emailed to the intake address box, we've received it, but you will only be contacted when, the intake worker has looked at the referral, and if that referral is appropriate, they will be in touch within a few days. There is only one intake worker at DePaul House, which is probably why I am able to facilitate this session and have a good understanding of how it operates, just because at times I've often had to assist with the volume, especially post-COVID and the massive spike in referrals we've had post the lockdown. So, look, it's something we'll look at. If it would make people feel a little bit more heard, or if they have something to then discuss with their clients and kind of give them that reassurance, then we're happy to look into it.
Okay, thank you. Thank you. There is one more question about when a referral is not accepted due to individual's complexity due to medical diagnosis. Could you explain what is best focused on in order for the client to be reconsidered? Who'd like to start? Rebecca?
Sorry. Can you repeat the question, Sandra?
Yes, of course. When a referral is not accepted due to an individual's complexity due to medical diagnosis, could you please explain what is best focused on in order for the client to be reconsidered?
Look, it's really case by case. The client could be declined for many reasons. One of them could be medical acuity. It could be sexual safety. It could be that they have already detoxed and we don't view them as actually requiring an admission, and it's just simply a requirement of a rehab or the next steps that are wanting them to be admitted to withdrawal, even though we don't actually see it as something that requires medical input. So it all depends on what information is given to you by the intake worker, that you specifically hone in on that feedback and come back to us once you've got a plan around it. Or if we will always try our best. I know our intake worker, Emma, will always try her best to defer or kind of direct the referrer to the best person that they feel this referral should go to.
Thank you. And Goldie, much the same for?
I would say similar, but because, as I've mentioned before, we don't have the 24-hour nursing staff, it's a bit more difficult for us to re-review a client if, medically they're quite complicated. There have been times when clients' physical health has become more stable, or their mental health has become more stable, or perhaps they've reduced their substance use. Then we are definitely open to re-reviewing their referral. But it's very much case by case, as Becca said as well.
Okay. I think that's probably nearly coming to the end of all the questions. I'd like to thank all of those people out in webinar. Feedback from and responses from Goldie and Rebecca. If you've got more questions, as I said earlier, please don't hesitate to contact both presenters directly via their email or phones. They'd be more than happy to guide you through some how you might respond to some of those. We did get lots of questions that, as they said, were submitted earlier, and I think they've probably responded to most of those. And again, if not, please contact. We'd like to, and this comes from the presenters and the team of people behind them, the intake and assessment workers, that there's a thank you to all the adult alcohol and other drug residential services community for providing guidance and feedback in the development of the webinar. And as we mentioned earlier, there's a tip sheet for you to download that you can access. And it's recognised that this information is a result of sector-wide collaboration and input from all intake clinicians across Victoria, and is valued and appreciated. So a big shout out to everyone involved. I think it's it's really great to have clinicians who are in doing this work on a day-to-day basis presenting, because we often don't have the direct workers, so we're really, really pleased to have you here. I'd also like to just announce that there's a bit of news from Turning Point. There's not only the Connect and Learn webinar series that you can access via the Turning Point website, there's a new graduate program in addictive behaviours that was just recently announced on VADA for 2021. So if you're interested in some further study or some study, please go and have a look. It's a really great opportunity, and there's a number of scholarships available. So please don't hesitate to go browsing. So that's probably all from us. We'd like to thank everyone involved. Thank you again very much to the presenters and everyone behind the scenes who is assisting us today in what seems like a very strange setup, but well, hopefully we will be back to some kind of normal within a few weeks or so, or maybe by the end of the year. But I'm being positive. So thank you once again, and that's all from us.